I'm going to talk about venous strokes, and the significance of this is that it's not as common as the arterial ischemia. At the same time, all of us practicing neurovascular or neurointervention will have a case like this once a year, twice a year, and that's all across the globe. And since there isn't a definitive protocol or huge experience, I try to share what we have had over the years in India. So, for the next 15 or 20 minutes, I will try to share with you what we have done with the venous strokes that we have encountered. As I already said, it's arterial strokes. I think it's a set protocol. Everyone is doing numbers, and the numbers are going on increasing with every single day. Venous strokes are not common, and because they're not common, most of us do not know how to treat the severe ones. It's okay about the run of the mill venous strokes, which is something like 80% of venous strokes are milder variety. And so they respond very well to the conservative management and to anticoagulation and heparin. But in the severe ones, because there isn't enough experience and there isn't a protocol, that's where we would struggle. So this is an attempt to actually let you know about what we have been following for a very long time, and it is working for us. So maybe it can work for everyone else. So in the severe variety, let us see if there is any evidence, any trials, any single center or multi-center experience which has been published. And so these are some of the papers which have been published. I'm not going to go through all of them, but just to be very short, let me just come to this slide, which is a summary of all the papers which have been published on venous stroke. What you need to know is that there isn't any blinded or double-blinded trial. There isn't any huge cohort or number of patients which have been studied. And so the evidence is low. Most of the experience which is shared and published in literature, including ours, it can go only as low evidence. And so all the same, this is not going to change much. And so try to understand and learn from someone like us who have had significant experience treating venous strokes over the past a couple of decades. This happens because it is not so uncommon. Something like up to 20% of young strokes in India can be venous strokes. And because of that, the number is significant. And predisposing factors are many, and I have added in a different color the recent one that we had, unfortunately, in the last couple of years after the post-COVID vaccination. And I'll be sharing the case that we did with it. These are the other factors which are common with all the population all over the world. And so what's the pathophysiology? What do the venous strokes do? In our opinion, there are two different and distinct varieties of venous strokes. Either it is a severe fulminant form or it's a milder variety of venous stroke. And those are completely different and should be managed completely differently. Now, this is a fulminant venous stroke. You can see that it begins with an extensive thrombosis of the cortical veins and sinuses, and it progresses very rapidly. It progresses from small infarcts to larger infarcts to hemorrhagic conversion to large hemorrhages. And then there is a lot of congestion of the brain because of which the functionality of the brain goes down rapidly. And this is the subset of patients who do not do well on conservative management. For example, day of the ictus and next day, you can see that if you do not treat them in great urgency, these patients will go down and we will lose them in no time. And this happens even today. Again, I'll be sharing a case with you at the end of the presentation. Small little petechiae can turn into large hemorrhages, and this can happen very quickly because the venous ischemia or the venous congestion is an unpredictable disease. The 80%, luckily for us, most of the venous strokes are milder variety and they do not progress. So they do very well with the conservative medical management. But this presentation is not about these strokes. It is already established decades long. So the management of the severe venous strokes has to be done with dural sinus thrombolysis, which is vast of our experience, or thrombectomy, as the recent experience is. I will try to share with you that when do we do it? We do it when a milder or moderate variety of venous stroke is not responding to heparin and anticoagulation, or right from the beginning, it's a fulminant venous stroke, so there is no time to lose. And both these patients are indications for selective thrombolysis or thrombectomy. How do we understand that which patient goes where? So we have a very, very simple protocol for the grading. The first is clinical grading, the second is imaging grading, and the third is DSA angiographic grading. We can divide them into the mild variety and the severe variety, depending on how bad the patient is or how well the patient is. Similarly, we look at the imaging, and in imaging, we see if it's a milder disease or it's a terrible life-threatening venous infarction. And so there are all numbers given. It's very, very easy to follow. Whoever wants it, I can share this protocol and this grading with them. And the DSA grading is from recanalization or rerouting to severe restriction and severe congestion. Now, candidates for thrombectomy or thrombolysis, as I told you, they are the severe grade patients or the moderate grade patients who are not doing well or who are going down in spite of medical management and in spite of anticoagulation. So the protocol, what is the protocol? I'm going to tell you how to do it. We go transvenous. Most of our transvenous access is in the femoral vein, and then we go up and keep the guiding catheter in the jugular vein, whichever one is the one that you want to take. Mostly you should take the jugular vein, which is patent. You go inside with a microcatheterization, confirm that you are inside the thrombosed sinus segment. This is not about cortical veins, this is about a thrombosed sinus only. And then you can start the thrombolysis. I'm again saying thrombolysis because almost all our experience has been with thrombolysis. Only recently we have shifted or we have added mechanical thrombectomy. And I'm going to share that experience with you as well. But if you need, most of our experience was with urokinase, and now in the recent years, we have been using TPA, and this is how you do it. It's a lysis. It's not one shot treatment. It goes on. It's infusion, and it goes on over several hours, sometimes 2 or 3 days even. How long do we do it? The patient will respond very rapidly. An unconscious patient will just open his eyes, and the patient who is disoriented will become oriented. And of course, you have to check it on selective venogram and an angiogram, whether the sinus you're lysing has become open, has become patent, or you still need to continue. So it needs to be both clinical recovery at the same time angiographic recovery. We did all this years ago, so I must accept that this is not a very recent study. In fact, we did this between 1997 to 2006. So that's 15 years ago. The good thing is that this is standing us in good stead because whatever that we studied back then over a number of patients, nothing much has changed. So we studied a few hundred patients, out of which 85% of patients in acute venous strokes who would have died, almost nearly 100% mortality. 85% of those patients we were able to save and save them well. There was still mortality, but that's basically because we didn't do it early enough or there wasn't an early reference. Mild variety, there should not be absolutely no reason to lose a patient of venous thrombosis in a mild variety of patients. It resulted in a paper. It was published in Interventional Neuroradiology, where Pierre Lejunias and Marco Leonardi used to publish a journal. It is still there, but unfortunately, the impact, the penetration of this journal in the operators is not too much. So even though the paper is there, it is not available or they cannot see it. So look for it, you'll find it. And all our experience is there in that paper. So let us come to the actual doing of cases. Venous strokes, which are either going down or venous stroke, which start as a fulminant one. And I'll share all of them with you. So this guy was rapidly going down, As you can see that there is bilateral hemorrhagic venous infarctions, petechial hemorrhages. We take this patient up and the DSA pretty much shows nothing. This is the venous phase, and what do you see? You hardly see that there are any veins except the deep ones. Apart from that, we don't see any sinuses. And so no wonder that this patient is not doing well. As I said, the first thing, transfemoral, transjugular, keep a guiding catheter and try and get your Terimo wire inside the sinus. 80% of our experience has been in the sagittal sinus. So you go with the wire, you macerate the clot 2 or 3 times anterior, posterior, to and fro, and then you put a microcatheter. You put the microcatheter and then you check that it is inside the thrombus segment. Once you do that, you start the thrombolysis. And the picture I'm showing is amazing because when you have a beautiful picture like this, it's a normal venogram. How did this happen? It happened by lysing the clot in the sinus. And the clot in the sinus was lysed, so the veins, the cortical veins, could again enter, drain into the sinus. This results in immediate decongestion of the brain because of the rerouting. And once you have pictures like this, the patients do exceedingly well. Most of them are MRS of 0 to 1. This is just to compare. The pre is on the left and the post is on the right. This is by infusion thrombolysis. Let's go to the second case. I'll just show you a couple of cases and then let's move to thrombectomy. So this patient actually had symptoms like spine. And so first, the spinal MR was done. The dorsal showed nothing. Lumbar showed nothing. But the whole spine imaging accidentally included the brain, which showed, oh, wow, there's it. Let us now image the brain. And the brain showed what it was, bilateral venous edema and infarction. Immediately, we took the patient up, and this was the venogram on MR. The sinus is gone. And you see that because of that, the patient is going down quadriparesis because of venous infarction. The angiography shows that there is stagnant veins. They cannot enter the SSS because it is thrombosed. We do exactly the same thing. We go inside the sinus, the microcatheter venograms show thrombus inside. We start the thrombolysis, and over the period of hours, 10 hours, 12 hours, 24 hours, whatever that it may take, you lyse the sinus. You open the sinus so that the veins, the cortical veins, which were not draining before, can start draining. Once you do that, the patient will make gradual recovery. Of course, you will give anticoagulation and the supportive management up to 6 months. And then once you do that, when patient has made full recovery, you should do the MR venogram to follow. The beauty of coming down from transfemoral is that you can just go everywhere from one axis, from the SSS to both the lateral sinuses, sometimes straight sinus. And so veins is not one territory because the sinuses can be central sinuses or lateral sinuses, and all of them can be accessed through transfemoral route. And once you do that, as you can see, lysis opens the sinuses. This is the post picture, which shows full recanalization of the venous circulation. Needless to say, by now you know that when you have beautiful pictures like this, the patient will do exceedingly well. As I said, every single patient goes to have a follow-up MR venogram so that we know that something surprising is not happening. By that, I mean a dural fistula or a rethrombosis of the sinus. What about mechanical thrombectomy? Thrombectomy, because now everyone is doing arterial. So everyone is well versed with the mechanical thrombectomy and how to do it. We can do it for the venous side as well. The ideal situation is where it's not an extensive thrombus. The thrombus is limited, and once the thrombus is limited, you can do this maybe 2 times, 3 times, you can do the thrombectomy and remove the clot to have pictures like this. But most of the times I've seen that after thrombectomy, you don't have beautiful pictures, which I showed you, which were the pictures of thrombolysis. You have pictures like this. Nevertheless, if the patient has tided over the crisis, it is still good. Another thing you can do is get a long peripheral balloon. These balloons are generally used for the tibial and the femorals in the leg. So you can get a long balloon inflated, and that will create a burrow inside the clot, and then you can do the lysis. I'm going to share with you one more case which was done. Again, not a very severe clotting of the sinus, but it is a focal one, which you can go inside and do mechanical thrombectomy. And once you do that, maybe 2 times or 3 times or 4 passes even, you will open the sinus. And once you do that, as I'm saying, it is a definitive one. The medical management will continue and the patient will do well and go on towards complete recovery within 30 to 90 days. Now, this is the case I'm going to share with you. This was a recent experience. This is a post-vaccination venous thrombosis. It was an extremely traumatic case. Luckily, we were able to intervene. She came like this with a convulsion 15 days post-vaccine. First, it was reported as SAH, no management, and she continued to have convulsions, and then she continued to deteriorate clinically. The scans looked worse, and now, of course, it was diagnosed as a venous disease, and still it is not too bad. It's not too bad. At this point of time, anticoagulation was started, still no reference to us. And the anticoagulation started, medical management was done, but it didn't help at all. Instead of thrombolysis, she underwent decompression. We will come to that as well in the next 1 minute. Decompression may have saved her life, but it did not really improve her clinical condition. So over the next 3 days, she went down, her platelet count went down. So we have pretty much no option of thrombolysis here. We did not have time, and we could not inject with so low platelet count. We could not inject a lytic agent inside the sinus. So this was a scan before we intervened. It looks as bad as it can get. So more or less, she was gone, but we said we should give her a try because her pupils were still reacting. And so 1 week after the onset, we went inside. Several issues were there, but we still said that we will go ahead. And we went inside. We did the thrombectomy from both the jugulars, and we put 2 systems inside her SSS. And you can see that there are 2 systems of aspiration as well as stent retriever. And then we pulled it out 5 times. And when we did that, this is how she started with. Angiogram looks okay, but the veins, the sinus is completely thrombosed. You saw how bad the CT scan looked. And this is how we finished. When we finished, it is still delayed at the same time. You can see that the sinus is now antegrade. As I said before, sinus antegrade, the veins can actually drain into the sinus, and this is what causes recovery of the patient. This is what we finished with. This is what we got out. Pictures like this are common on arterial side, not common on venous side. The pre and the post, there is significant difference. We did the angiogram the next day as well, which looked even better than the previous day. And then slowly we left her towards a gradual recovery. She made an excellent recovery from the time that she was comatose. And now she's walking maybe a little deficit. And that deficit is actually because on the side of the decompression, that this is her follow-up venogram, absolutely fantastic. And in 6 months, she has made a remarkable recovery. This is a scan, completely quiet brain. Unfortunately, the problem is on the side of the craniotomy. Now, let us come to the last part of this talk. What about surgery? There have been a few papers and there have been a few short series and individual experiences on decompression in venous infarcts. Let's begin with this case. Admitted with seizures, young boy. The scan looked like this, and still no real treatment was started. If the scan was looked at properly, you would see that there is the sinus which is hypertense. He continued to seizure, he continued to go down, and now the MR was done. Again, no venogram, but MR angiogram, which obviously did not show anything great. And this is the MR bilateral hemorrhagic venous infarctions. Unfortunately, this boy, young boy, salvageable boy, he came, and because of lack of protocol and lack of understanding and lack of awareness, we lost him eventually. And this should not happen. So he came to our hospital, again, no reference to us. The first reference went for decompression. He was decompressed, bilateral, the brain looked like this. All of you are neurospecialists and neurointerventions, so you know what is happening here. We still tried the angiography. It looked like a circulatory arrest, fixed dilated pupils, arrest on arterial side, arrest on venous side. There's nothing. No blood is coming, no blood is going out. And unfortunately, he's comatose with no brainstem refluxes. We lost him. This should not happen. And so, in conclusion, I can say that we have a role to play, even though not in all the cases, but those cases which are severe, those cases require our attention rapidly and urgently, with thrombolysis, as our protocol says, and with thrombectomy, as the recent trend is. But we should do something. We should put our shoulder to the wheel, and more often than not, these severe grade patients also will recover. I thank you for your attention.